Okay, so today we'll discuss tumor RAD systems. So we'll basically focus on soft tissue and bone tumors. So my screen is visible, everything is okay?
Yes, sir. Perfect audio and visuals.
All right, great. Okay, let's see. So these are my disclosures, but I have no conflict of interest. So to introduce radiologists across different experience levels and institutions tend to use variable terminology to describe similar MSK tumors. So for example, if it's a non-ossifying fibroma, somebody may use the term do not touch lesions, some may say NOF, some may say FCD, fibrous cortical defect, etc. So there are different terms. And secondly, we are not correct many a times. Like for soft tissue tumors, the accuracy of even an expert radiologist is only 50 to 60%. So if I show you a tumor and ask you, is it a synovial sarcoma or is it fibrosarcoma, you may not be sure. So even pathologists, they apply different markers before they come to one diagnosis. Sometimes they'll say suggestive of this diagnosis. So there's a lot of variability. So that's why standardized terminology and scoring systems should be used for bone and soft tissue tumors. And this will help in tumor risk stratification scoring, meaning are we looking at benign or intermediate grade or malignant? So you can stratify based on a score, just like by RADS from 1 through 5 or 1 through 4, whichever system you use. And one can define management planning tools or recommendations in your practice. So that way you can hope for that there is improved RAD path concordance or proper communication between the interdisciplinary teams so they get some guide to how to follow. And there are differences all over, like some people follow in 6 weeks or 3 months or 6 months, so depending upon scoring systems which are out there or your own practices. So we'll focus first half hour on bone tumor scoring, the second half hour on soft tissue scoring, and then we'll go through some cases at the end. So let's look at bone tumor scoring. So the first one, which is popular, is bone RADS. It was created by Society of Skeletal Radiology by a committee of 12 radiologists and one surgeon with expertise in bone tumor imaging. This was initially published on X-rays and in 2022. It focuses on diagnostic management, which I think is a right approach, that you focus on management rather than saying that this is benign or this is malignant. If you're sure you can get there. If you're not sure you can get there, you can just focus on the management, meaning what to do about what you see on the X-ray. And then initially this was a ACR effort on the X-rays. Then Connie Chang from MGH, she spin out a product out of this through SSR on CT and MRI. It was a 4-point scale. So again, these are the 4 types of management. Either you leave it alone or perform a different imaging modality, perform a follow-up imaging or biopsy. But if you look at the system, your role as a radiologist is minimized. So you are taught all your life, call this lesion, look at this periosteal reaction, is this and that, is it ABC, GCT, this and that. And here you're not saying that. You may be saying in your report, but ultimately you're just guiding them to do something about it, which would be correct if the system worked. So let's see how the system works. So there are some points in this bone RAD system which are based on what you see on the X-ray. So these are your Madewell classification. So John Madewell is in MD Anderson. He's still around. He's a chief there for MSK radiology in our state, great state of Texas. So he came up with these margins which you learn during your residency, that you have a geographic well-defined lesion with marginal sclerosis, and you call that benign. So it gives you 0 points essentially. On the other hand, if you have a lesion without marginal sclerosis or ill-defined margins or changing margins, you get more points. So based on these, the number of points you have, you characterize them into very low risk, intermediate, or high risk. So right now, there is not much literature on it, meaning what is very low risk mean? Is it 2% or 1% or 10%? What is low risk? Was it intermediate? Is it 50%, 60%, 70%? So there's not much literature in bone tumors because they're very low in frequency or prevalence in the population. And right now I'm building soft tissue RADs, which I'll touch upon for ACR. And they're asking the same question, can we put some percentages? And we did those percentages in the ST-RADs in the initial system, which I built in. At that time, the reviewers didn't like it. They said, where's the literature? What is it based on? And now when I took it out of soft tissue RADs, the ACR people are saying, where are the percentages? So you can see there is a big dilemma there. Now, the advantages are it has defined diagnostic and management algorithms based on the point system. It's created by a committee of experts, so-called experts, who participated in the ACR committee. And this is for solitary bone lesions, which have highest degree of inconsistency. I don't know what that means, but that's how they put it out there, that they are not consistent, meaning they're not sure what's going on with those lesions. That's why they give points. And system can standardize patient care and physician communication. It's applicable to all radiologists who look at those X-rays, especially non-MSK radiologists. They can give some points based on the margins, etc. And there's a decision tree approach. But there are disadvantages. There is no testing on this system. It would benefit from some sort of validation. I mean, four experts sat down, just like your diagnosis of dish. Three radiologists sat down and they said three or more levels of syndesmophytes, you call it dish. Nobody knows what that dish is. It's just big syndesmophytes. It can be cumbersome to employ in daily practice. And many benign lesions get into bone RADS 4 category. So if you have, say, a giant cell tumor or something which doesn't have much sclerosis, they can get into that system. And they didn't use a WHO classification of tumors. So I don't know how many tumors fit in there. And then bone rat CT MRI scale came out, which was spin off by Connie Chang. So again, they use the same system. And they divide the lesions into lucent lesion or sclerotic lesion. So this was again arbitrary, but they said a lesion which has lower attenuation than the bone and greater than 90% of the lesion is lucent. They called it lucent. And then there are a bunch of these charts out there, but they ultimately end into this bone rats 1 through 4. Now, if you look at these, are there any aggressive features? So pain attributed to the lesion. A lot of lesions cause pain. What does that mean? That means they straight away go into bone rats 4. So you may have eosinophilic granuloma, you may have infection, you may have Mets, myeloma, so bunch of these. So you actually cannot say that these are malignant lesions. All you can say is these are aggressive and straight away they go suspicious for malignancy or need for treatment. So again, you're taking the whole radiology you learned all your life out of the bucket. And all you're saying is anything pain, any cortical involvement. So what can involve the cortex? Any cortical gangrene, which is benign, any osteoidostoma, even hyperthyroidism, hypothyroidism, they can cause cortical lucencies. So you're sending it straight away there. So it's a very conservative approach of treating these lesions. So that's why I don't use this in my system, but you have these charts for your disposal. So same thing for sclerotic lesions, etc. And then they use MRI, whether it's low T1 compared to muscle or disc. So then you have this chart, and then high T1 for solitary bone lesions. So these charts are out there, and I have no intent of remembering these charts. But you can if you want to use the system in your practice. So advantages, it's a smaller scale, 4, 1, 2, 3, 4. Need to remember multiple algorithms, which I don't think any radiologists or any doctors like to remember these algorithms. Uh, if you look at there's data out there that in our electronic systems like Epic, where we store patients' data, if you put algorithms or if you put any sort of teaching tools, the doctors don't look at this. They actually ask their colleagues to say, okay, what do you do for this condition or what drug is working in your system, and they'll start using that instead of looking through all that data because they have read all their life, all these books. Nobody wants to look at more algorithms. And it's a management focus consensus guideline, which is a good thing. So disadvantage is a conservative approach to not miss any bad lesions. There was no pathologist involved. They didn't do any validation and difficult to place different tumors in different categories. and they put an arbitrary follow-up, 6-month follow-up. If you look at our system, if you're suspicious for anything, they'll follow up in 6 weeks or generally in 3 months. And some of our tumor guys, they even after surgery, they follow in 6 weeks and then 3 months. So 6 months is too long. So it's challenging for any longitudinal data collection or outcomes tracking. And it's basically a bunch of flow charts created by a few experts. So there was one validation study done by Charlie et al. From University of Washington. They took 103 lucent lesions, and he was part of that bone rat system himself, and 76 sclerotic or mixed lesions. And in those, you can see the sensitivities for the lucent lesions were high, meaning you're picking up most of the lesions. But if you're excluding the malignant ones, specificity went to 11%, which is nothing, right? So same for sclerotic lesion, the specificity went to 27%. So this system is not going to work that way. Then there was another system which was proposed a year before that in 2021, and this was called BTI RADS. And in that, they had 3 radiologists, 2 MSK and 1 general. This was out of Europe. They had about 230 tumors, and they showed a kappa, which is inter-reader agreement of 0.67, which is moderate. And they used known lesions, but they had different indicators. So there were 7 benign indicators, so you remember those. Then 9 malignant indicators, 6 minor, 3 major. You remember those, you use ACEs criteria, etc. For rheumatology, you have this minor, major, or rheumatic fever and all that. Who remembers those? But they had all these indicators. And based on the number of positive indicators, the authors proposed again a 4-category reporting system. So the good thing is this is talking about what we learn all your life from benign to malignant. Features of do not touch lesion, that's clearly benign. Features which have more than 3 minor malignant indicators go likely malignant. Then you have in between likely benign and something suspicious. But the other issue with this system was there were 6 indicators from CT and 7 from MRI, which means you got to get CT and MRI in each case. And 3 were general indicators, whether it's a pelvic or extremity location. And we see so many pelvic lesions which are benign, right? You'll get all these chordomas. Chordomas are on the intermediate scale. But say if you have notochordal RAS, you have hemangiomas, you have even enchondromas you can get in the pelvis, so you can get hemangiomas. So that location just by itself should not mean that it's a bad location. So it's not a single modality. So you got to do both of them. So it's a costly system to do it. Then the third one which came out was the REST score, radiological evaluation of score for bone tumors. And this was based on simply X-rays, and there were no radiologists. There were 2 orthopedic surgeons and 2 surgical oncologists. And they used 8 features. So what are those 8 features? I think these are the features you look for when you look at on the X-rays. You look for whether it's a lytic or a sclerotic lesion, whether it has any mineralization, osteoid or chondroid matrix, cortical breach is there or not, is well-defined or ill-defined. So they didn't use them Madewell log classification. They just use well-defined or ill-defined, which I think that's what you talk about. Is it, has a sclerotic margin, no sclerotic, narrow versus wide transition. So narrow transition, for those who are not taught what they are, narrow means you can etch with a pencil. Like you take a pencil and then you can draw a margin around it. Anything more than that is wider. Any periosteal reaction, whether it's absent, benign type or malignant type, soft tissue swelling, path fracture. So I think these are the features you use in your practice as a radiologist. So this is more a radiological system which is devised by surgeons. So then suspected benign lesion, if you have a score less than or equal to 3, anything more than 3 will be suspected malignant. Then what they did, they tested it. They took 100 X-rays of bone tumors which are proven. Then they found high diagnostic accuracy, area under the curve of 0.92, larger than any system we have heard till now. And inter-reader agreement was also very high. It was found that REST score of 3.5 was the most sensitive. And they also found as the REST score increases, it goes from 3 to 5 to 6, so does the probability of the lesion being malignant. So I think if you were to use something on X-rays, I like this score a lot. But the issue is that they only used X-rays, so it's only for X-rays. And secondly, they use 49% malignant lesions. So there's a big spectrum bias, and we know that if you are in practice, the malignant lesions are less than 5% or even smaller number. Mostly you deal with benign lesions. So if I throw in eosinophilic granuloma, Erdem-Chester disease, like all sorts of benign lesions which can mimic malignancies, the scoring, everything will go down. And this was taught to me by Dr. Jaina, who studied MRI in India a long time ago. He said every modality or every scoring system starts very high, 90%, 95%, because you are controlling that data. But when it diffuses into the public domain, it slowly falls to that 50, 60% accuracy. Like when MRI came around, everybody said, oh, every plaque you see in the brain is MS. But it turns out that most of these are small vessel ischemic changes. So if you give somebody to look at accuracy for MS, I mean, it will fall to that 60, 70%. And then at the same time, in 2021, we published our OT-RADS, which was being built in 2019 to 2021, conceptualized in 2019, before all of these systems. And then to do scientific studies, it takes time. So what we did, we used 5 radiologists from Southwestern. We had a surgeon also and a methodologist. And we looked at bone tumors, anything more than 1 cm. And this was mostly MRI based, but we put correlation modalities in there, meaning 112 had X-rays and 12 had CTs. So almost all of them had some correlated modality when we gave these cases to the radiologist to read. And we used a 7-point scale, very much based on what BIRADS was. Because one of the things with all these scoring systems, you want to keep it simple, you want to keep it what people can remember, and then give flexibility to them so that they can use their knowledge, what they have learned. So among them, 77 were benign, 55 were malignant. Again, we had larger portion of malignant than you would see, but if you were to keep so many benign and less malignant, you need a lot of, you need a very large sample. And having 3 modalities in there, again, becomes tough with all the reference standards. So we had 4 radiologists who tested it. So I recused myself because I knew all the cases, so I didn't read the cases. And we found high area under the curve, just like you saw with the RAS score. And inter-reader agreement was good, so about 0.75. So this is how it looks like. So we gave flexibility in the system. So 0 means incomplete imaging, meaning you need to have complete imaging, you need to have T1, T2, and contrast. So we kept it very basic, not diffusion, but T1, T2 contrast, you need to have that. So if you're missing something, you can either call for additional imaging or wait within 2 weeks if there was a prior examination that can complete the study. Because we want to give flexibility to low-income countries also. So say if somebody had a study and they just came for contrast in 2 weeks, that still completes it. Because tumors don't change very fast, in less than 2 weeks, most of them. So 1 was negative, you don't see anything. At that time, no further imaging follow-up. So we put percentages here. So essentially 0. 2 means definitely benign. And at that time, this came out of our dictation system. So we had some safety events where radiologists didn't recommend anything and then patient got lost. So our clinicians asked that we should have a recommendation section in all of our reports, X-ray, CT, or MRI in all sections, body, chest, or neuro, whatever. So in case we didn't see anything, this went as a default. Follow up as per clinical team, it goes back to clinical team. But if patient had a collection or tumor, then we created some electronic ones for our system that follow up in 6 weeks or drain it or XYZ. So this came from that. And then 3 is probably benign. So in this case, you have less than 2% chance it's going to be malignant. And I'll show you which tumors fit where. So here you have follow-up recommendations, and we use what most people do, follow up in 3 months, then double it. Now it can be shorter if the lesion resolves or significantly regresses. So if you have a heterotopic ossification, it ossifies or disappears or becomes small, you can stop right there. Then 4 was suspicious for malignancy for indeterminate lesion. So now you're getting up to 50%. And in that case, either you go straight to tissue diagnosis or you can do a very short-term follow-up. And if indeterminate or negative on tissue sampling, you further follow up and discuss in the multidisciplinary teams what to do about it. Because path can be falsely negative in some cases if they didn't get the representative material. 5 is highly suggestive malignancy. So here you straight away goes to tissue diagnosis and you have more than 50% chance it's malignant. And 6 is a known biopsy proven. So if you have a lesion like desmoid or if you have malignancy which has been treated, so this is not in the system, but when we put that in an electronic system to apply, so we are in a big university, so whatever you develop or create, you got to put that in system to test it out. So now we have about 700 cases on this in our system with OT RAD system. So we have in that system 6 A, B, C. So A means is resolved, B means partial response, there's something still there, and C means looks worse. In that case, you may go for surgical excision or further treatment as clinically appropriate. So if you look at OTRADS2, which are definitely benign, so 1 is negative, right? So we didn't have any negative cases when we tested, we just tested 2 through 6. So it's definitely benign. These are the lesions you know of, that you leave them when you see them on X-rays or CT or MRI, the lipoma, cyst, aneurysmal bone cyst, non-ossifying fibroma, osteochondroma, hemangioma, and chondroma. Leaving means that the clinician may still opt to treat, but basically you are saying that no further imaging for 1, and then for 2, follow up as per clinical team. If you want to follow it after treatment, it's up to you when you want to follow it, but we are calling it benign. And then there are criteria listed, which you already know in your practice, so I don't have to go through that. Now we put by expert opinion some ADC values which we think are true to these lesions, so we put that in there too. So here are some examples. And then we gave it to 4 readers. So 2 readers said 2, 2 readers said 3, but 2 and 3 both are benign. One reader tried to follow it, the other reader didn't want to follow it. But basically, you can see these cartilaginous calcifications very bright on T2. It causes some endosteal scalloping, less than 50% of the cortex. The size approaches 4 to 5 cm, so it's okay. I mean, and chondromas can be large. And then you can see there's only peripheral enhancement there with some stippled enhancement. So to me, I'll call it 2. Then 3 is probably benign, so they had some characteristic imaging signatures. So one of the things which reviewers asked was, can you put some suggestive features also? Then we put another table in the paper which suggests, what's the classic for histiocytosis? Like they have these geographic margins sometimes, they have some edema around them, and a younger age, XYZ, right? So we put those features in the intraosseous myxomas, you can get in ribs, chondromyxoid fibroma, which are eccentric distal femoral lesions. So we put some features out there: giant cell tumor, chondroblastoma, synovial chondromatosis, and chondroma protuberans, FT. Now, given that it looks like a giant cell tumor to you, and by experience you can tell this is where it happens: distal femur, lucent lesion, eccentric, and reaches the subcortical surface. If you see all of that with no sclerosis, okay, giant cell tumor. If you are a little bit confused about it, you can always put in OTRADS 4. That's fine. Anybody can get confused. But we gave very open approach rather than very conservative approach to people. So these are the follow-ups, and then they show variable enhancement. So say if it's a myxoma, it'll show peripheral enhancement or central. The giant cell tumor, it may show nodular enhancement also. Chondroblastomas can show nodular. So it's a variable enhancement. FDs don't show much enhancement, mostly peripheral. And then again, they have high ADC values. So these are some examples. So there's a classic one. So you have in the distal femur eccentric lesion, and then in this, there's extensive enhancement also, very lucent, no sclerosis at all, no periosteal reaction. So this will be a giant cell tumor, and this will be OTRADS 3, and then one reader thought it's 4. That's fine. So then we get into 4. So 4 is now you're getting above 50% or so. Sorry, you're getting into 2 to 50% range. So in this case, they become indeterminate. So you have deep endosteal scalloping. So here your atypical cartilaginous lesions can come in osteoblastoma, grade 1 chondrosarcoma. So getting into those lesions, they start to become aggressive. And then again, they may have solid appearance, and they may show variable enhancement, and mean ADC is getting to lower values. Basically, your cellularity in the tumor is increasing, but still above 1.1 usually. So here's a chondrosarcoma. So two of the readers said 4, two said 5. That's okay. 4 and 5 both we are thinking malignant, so they should be biopsied or should be very short-term follow-up. And 5 is highly suggestive of malignancy. So in this case, now you have bad lesions. They're very classic: osteosarcoma, Ewing sarcoma, pleomorphic lymphoma, myeloma, Mets, etc. So like this lesion, cortical destruction, soft tissue mass, big lesion, heterogeneous. So that was a Ewing sarcoma, and everybody called 5. So these are easy ones. So anyway, this was the inter-reader agreement, 0.78. These are the confidence levels. And then benign versus malignant. Um, um, when we did so we asked them a few other questions. We said, okay, what do you think is benign or malignant? Give us just two scale agreement. And there you can see their kappa was lower. But if you gave them the score and then they divide into 1 through 3 versus 4 and 5, they were higher. And then we also asked them, give us signal characteristics. Tell us if there's peritumoral edema, what sits on T1, T2, all that. And when we looked at their ICCs for that, look at that, how low they are. So we all describe things differently. And these are the accuracies for 4 readers. They are the experience level. One was 33 years of radiology experience, one had 2 years of experience. So we had wide experience levels, but everybody did quite well. It's 0.92, 0.92. In fact, 33 experience was 0.95, and then the 2 are 0.97. So not bad, So these are the ROC curves. So it significantly outperform individual tumor signal characteristics and binary distinction of benign versus malignant. So advantages. It has clearly defined categories, easy to apply with practical recommendations to guide further management and improve patient outcomes. It's a consistent lexicon with expanded scoring scale and use the WHO classification. So we put all the tumors in those buckets where it should be 1, 2, 3, 4, 5. 1 will be negative, but 2 through 5. Then excellent reliability and reproducibility among multiple readers. High sensitivity, moderate specificity, so ultimately high area under the curve. And it's also included and validated DWI, although we didn't formally test it. It was part of those tumors. So you would benefit from more validation, multi-center studies. So I know one study which has been done at University of Washington comparing different RADS, BTI, and all the RAD systems I showed you, and OT-RADs, and they found similarly higher accuracy for OT-RAD. The others are very poor. So it's not published yet, but I know of that study. And then reference standard for some cases were limited to those with minimum 2-year follow-up as benign appearing lesions, not routinely biopsied. So some of these lesions, like FD, we basically came with a expert consensus that this should be FD because some of these are not biopsied. So not everything had a reference standard. I think about 20 or so lesions did not have, they just had follow-up. It was MRI-based diagnosis, but with correlation with X-rays and CTs. And we didn't test DWI formally. So obviously our next step was to test it with DWI. So we took the same cases, and 6 months after that, when this study was published, we said, okay, look at conventional imaging, which we had already data. Now just look at conventional plus DWI, give us the confidence level, how confident you are benign versus malignant, and then we looked at their diagnostic accuracy. So for round 1, conventional imaging, you saw the ICCs. For round 2, it actually went down a little bit when you gave them DWI, so they're a little bit confused. And we didn't find significant difference in area under the curve for readers 2 and 4. But for reader 1 and 3, for 1 it went higher, for 3 it went lower a little bit. So 3, as you saw, was the one with 33 years of experience, not much experience with DWI. It went a little bit lower. But the average reader confidence became higher, it became 4.4. So they're more confident after looking at DWI, what they're dealing with. So here you can see it's another enchondroma shows some sort of deeper scalloping and very bright on ADC and diffuse sort of enhancement on contrast. So in round one, everybody said 2, 3, 2, 3. Now in round two, one of them changed. It changed to 2 again. So more of them said benign, and this was a benign lesion. This was just an chondroma. So here's a lesion in the distal femur again, and a little bit eccentric. But when we gave them, so it looks a little ugly, but if we gave them diffusion on ADC, it's very dark on ADC, which happens with giant cell tumor. They're very dark. So one said osteosarcoma, one said GCT, one said indeterminate, the third one said GCT. So they had 5, 3, 3, 3. And round two, everybody said 3, 3, 3, 3. Here's another one where there is destruction of the calcaneus, and again a lesion which is coming out of the bone, heterogeneous, and has areas of restriction, bright on DWI. So it's a bad lesion. So initially, people said osteo, bone cyst. One said one couldn't tell what it is, and they had 5, 5, 4, 5. So you can see here they said bone cyst, but they put 4, which is correct. It looks very aggressive, right? So they were thinking malignant when they're thinking OT-RADS. They were thinking benign because cyst commonly happens there. See what's going on here? So, but if you put these together, this is not a cyst, right? So then in round two, when DWI was given, everybody was again 5, 5, 4, 5. But if you look at the tumors now, they changed that cyst to giant cell tumor. So basically, now their confidence level changed. Okay, so what we found was the addition of DWI improves the specificity and positive predictive value of OTR stratification with increased diagnostic accuracy in ruling in conditions, but it doesn't allow significantly improved AUC. Now, already if your AUC is 0.92 to 0.97, you expect very minor changes there, even if you add any modality. So that's expected. But increase the confidence levels as you saw. But in general, the conventional MRI can be prudently used for reliable and accurate characterization. So if you don't have DWI, that's fine. Okay, so that's for bone tumors. Now let's get into the soft tissue tumors, and we can have a little discussion also. So in soft tissue tumors, we involve two other centers, University of Arkansas and MD Anderson, um, because these tumors are more heterogeneous, they're all over the place, and can be difficult sometimes with advanced imaging, without the advanced imaging. So we wanted to involve more centers, more types of cases. So we got cases, we contributed about 50, and then MD Anderson gave 100, Arkansas gave another 50. So 200 cases we tested with them. And we wanted more radiologists. So we had about 8 radiologists testing it, apart from me vetting the cases with a fellow. So a fellow at that time was Raghu Ratakana. He's back in India. So he did a lot of work on this. So soft tissue tumors are commonly encountered in everyday practice, and benign tumors are 100 times more common than malignant. So always think benign first before you think of malignancy. The known diagnostic accuracy, as I said, is 60%. It's in fact between 50 and 60%, not very high. If you ask somebody what's the diagnosis of the soft tissue tumor, and there are 0 inter-reader studies. So recently for soft tissue RAS, we searched the literature for over 40 years. We didn't find a single study which had done inter-reader studies. Most of these are review articles in radiographics, etc. So we had 8 radiologists, MSK ones, and the experiences ranged from 2 years to 30 years. So one had almost 40 years of experience from MD Anderson. A total of 200 soft tissue tumors were tested, 100 fatty tumors, 50 T2 bright, and 50 T2 black. So similar scale as you saw, similar recommendations, nothing different, but it applies to soft tissue tumors and similar percentages. Okay, and then we had some examples for them going from the WHO table. So a lipoma up to 10 centimeters has been shown. If you see a fatty tumor large up to 10 centimeters, still you can call it lipoma. Plantofibroma, fibrolipoma, elastofibrosis. These are the diagnoses you can make in your practice that these are benign, right? I don't have to teach you the characteristics. So we didn't put any characteristics in the paper as we were asked for OT-RADS. Then 3 is probably benign. So here you have a septate ganglion cyst, fibromatosis, so you have more fibromas now, heterotopic ossification, which can look aggressive, PNSTs, TSGCT, etc. If PNST shows you all the classic sign, it's got a target sign, a tail sign, or some high diffusion, etc., you can put it in 2. So it depends how sure you are. Uh, and then 4 is malignancies more than 2%, less than 50%, similar to bone tumor. Now you have atypical lipomatous tumor, solitary fibrous tumor, which shouldn't be making the diagnosis of benign or malignant just on imaging because you can be wrong. Gardner's fibroma, desmoids, etc. And then 5 are your classic malignancies, malignant peripheral nerve sheath tumors, pleomorphic sarcoma, leiomyosarcoma, lymphoma, melanoma, myxofibro, Kaposi sarcoma, all the bad ones go in there. Okay, so these are our tumors which we took from our setups to test. So you can see in 2, so somebody like expert like me who's leading the study or with another fellow or 2 experts have to agree what RAD score that should be based on pathology and imaging together before you let the other readers test it. So we came up with these lesions. So we had cases of lipomatosis, lipoma, fibrolipoma, fat necrosis, hematoma, etc. in fatty tumors. So hematoma with fat also. So these we put in 2 versus these ones with geyser, cyst, hemangioma, paralabal cyst, venous, T-gloving ganglion cyst. So these are your T2 bright lesions, which went to like this, right? So these are the tumors we tested. So here is a case where you can see it's very fatty, it suppresses on the fat suppress, it has pre-contrast, post-contrast, no enhancement at all. I mean, one vessel or something is enhancing. So this is a classic lipoma, no matter what the size is, right? So all readers called it 2. Here's a lesion inside the muscle. Inside the muscle, if you have a cystic lesion, we always think of myxoma. Now, these myxomas, if the patient gets older, you may have underlying myxoid pleomorphic or myxoid lipo or something, right? We could have that. We didn't see any fat in there. So different readers classified as 2, 3, and 4. Some went to 4 also, which is correct approach. That if it's an older patient, we didn't give them the age because these are anonymized studies. So it's an older patient, okay to call 4 because somebody may want to take it out. Here is a lesion which has septations, has some enhancement. So this was atypical lipomatous tumor in the muscle, and people called it 4s and 5s. That's fine. Here's a classic bad one. A lot of solid areas, sarcoma, everybody called it 5. So if you look at the results, for the hyperintense lesions, the ICC was 0.69, moderate. For T2 black lesions, which are harder lesions to diagnose, they again went to moderate, 0.51. So 0.5 to 0.75 is moderate. For adipocytic tumors, it's getting to that good level, right? It says good, fair, good, but you can use different scales. But they were not bad, I mean, except for this T2 hypointense. And in the hyperintense masses, if you look at their sensitivity and specificity, they were quite good. You know, here fatty tumor almost was 96%, 93%, and specificities were also not bad. So these are higher than what you have for qualitative diagnosis, which is barely 50 to 60%. And these were cases not from single center, 3 different centers. So this you can think of as a diffusion into the public of this knowledge. So then we divided the readers into less than 10 years of experience or more than 10 years of experience. And what we found was no differences, very similar in accuracies and in inter-reader reliability. So these were the ROC curves for those 200 tumors. So this is one of the largest studies now out there, apart from one from France, I think G. Allen, where there was no inter-reader study. This one has inter-reader analysis also for soft tissue tumors. So if you are doing a lot of soft tissue tumors in your practice, you should publish your data because in India you see a lot of cases, but this is one of the largest ones out there now. So advantages, so it had defined categories, again, similar to OT-RADS, clear practical guidelines what to do for the management. a consistent lexicon with expanded scoring scale and usage of WHO classification. So we took all 12 tables of WHO 2020 criteria and took tumors from that, which we see in our practice. Good area under the curve, good overall sensitivity for adipocytic and T2 hyperintense, higher than the qualitative Phelan diagnosis. For T2 hyperintense, it was slightly lower. And it's applicable to both general radiologists, oncoradiologists, and post-op imaging scoring was also there, just like OT-RADS. The disadvantage is, again, it would benefit from more widespread usage among non-experienced radiologists. Benign lesions can be called lesions, meaning if you have ganglion, you can call it ganglion, not a tumor, because public may get scared with the word tumor. So that's the improvements we're doing with the ACR work going forward. And there can be more expanded discussion of tumor imaging characteristics, which was not part of this work. And again, it's an MRI-based guideline, which I think is the best modality for soft tissue tumors anyway. So based on that, now ACR identified a need for ACR branded soft tissue RADS. They called it soft tissue RADS, not ST RADS. We called it soft tissue tumor RADS. So I'm the chair for that. And we did a work over last, I would say 24 months or so till now, and sending it for publishing soon. So the problems with the previous system was that the word tumor was used for non-neoplastic benign entities. The key imaging features were not described, as I told you. And then category 6, again, did not have 6ABC in the previous system. But in our PowerScribe, in our local system, we have it 6ABC. So that way, we have about 1,000 tumors in our system who are already graded with STRADS. So the next step we are doing is we are actually auditing our data of different RADs, STRADs, OT, and SRADs, etc., and musky RADs, what we have done in our system. So we'll publish those larger series also along the way. So there are three key takeaways. There's extensive literature review. So we went through 40 years of literature with different students and research assistant, and we vetted all those articles. So now you have tables and table summaries and different algorithms to go by. Again, you don't like algorithms, but these are just to guide. If you see this, what do you call? If you see that, what do you call? So that sort of algorithm. I'll show you a couple of examples. It's a more refined scoring system with management recommendations. And we also did validation testing. We took 10 experts who are part of the committee, 10 different radiologists. We also have methodologists, pathologist, a oncosurgeon, and also medical oncologist. It's a big committee of 17 people. And we took 10 expert radiologists and we gave them 150 cases. And they were also trained on 7 separate cases. So 157 cases they tested. So this is how the tables will look like. We have the WHO 12 tables. We condensed them into 6 tables to make it more manageable. And we combined some tumor classes. So you'll have those tumor classes listed here. Then which age group, size, or location they happen. What are the key histopathologic findings, immunohistochemistry, key clinical findings, X-ray, CT findings, ultrasound, MRI findings, any unique patterns which are described and have been tested, malignant potential, underlying syndrome. So you have that for all the tumors, those. And then this is how the scale looks like, very much like you saw ST-RADS, but here it's much more refined, meaning we have defined these tumors as tumor or tumor-like lesions. So tumor-like lesion are your ganglions, etc., all of that. So we have definitions of that. And then these management recommendations are more expanded. For example, if you are definitely benign, so previous was as per clinical team recommendation. So you have that here, but then you also have for a palpable or symptomatic hematoma or collection, clinical and or imaging follow-up to resolution. So this came from my fellowship when I did at Temple. There was a radiologist from HSS who would always say that because he was burnt in a couple of cases. So we have that there. And then we added this, that if it's a vascular malformation, consultation with a vascular interventionist. So there are more recommendations here, but essentially it's very similar. If you learn the first system, the second is also easy to apply. And again, this will take time to come out in literature. So if you have probably benign, we have similar. Now here, instead of 3 months, we have 6 weeks to 3 months. So we expanded a little bit to encompass what people do in their practices. And then we also have this tissue diagnosis of sarcoma or other prudent options, which means that if you wanted to get a tissue diagnosis, if you're very concerned, you're flexible to do that. And some people do that who do not have much training in radiology or not much confident or early in their career, they still want to get this done. So it's got more flexibility and otherwise very similar what you saw. So you have 6 ABC here. We also put out this structured template which you can use in your, so this came out of my book. Now the difference here is that you have different terms here, and my vision going forward in academics, we always think of 5 years ahead of what other people are thinking. So my vision is that we'll have an Ankita glass or REF glass, and you blink, blink, and the report gets filled. So you're clicking less because you have all these things in your template already. And this is how the next version of my book, when it comes out on structured reporting, will have it. It'll have all this things in there. And we have it in our parse guide system right now. So you can just click on ISO intense or whatever, and then your report gets filled very quickly. But in future, this should be by blinking when you're wearing a glass and reading your studies. Okay, the other very important thing, which is with any sarcoma diagnosis, is always think benign, benign, benign 100 times before you think of malignancy. What's the presentation? Is the infection going on? Is the patient asymptomatic? So we were at Hopkins when I was there. The surgeon will always come and say, "Oh, Avnish, what do you think? The patient doesn't have much symptoms." So that means they are thinking benign. I just have to say benign if it's beyond my reasonable doubt. And then if there's a history of trauma, surgery, or symptomatic mass, so then your differential changes. What's the location? Is it in the joint where you rarely get malignancies? What's the tissue reaction? There's a lot of reaction which usually happens in benign lesions, or very little reaction which happens with malignant ones. What are the key imaging features? So think of benign first before you think of malignancy. And then I have a separate lecture on this, but basically I always think of, could it be a normal structure? Does it have fluid? Does it have fat? So based on that, I have a differential. Is it predominantly T2 dark or adjacent to the joint or tendon or ligament or vessel or nerve? So again, these differentials guide me. And this is in my papers also. You can read that, how to exclude sarcoma. There's a paper in AJR. And try to do multiparametric imaging because soft tissue tumors are hard. So you want to do diffusion imaging. It helps you a lot. This case, I called it malignant and the pathologist said benign in biopsy. And then when the surgery was done, lesion was taken out. Still, they were calling benign. And I said, how come it's benign? It's so much restricting. It's got tumor vascularity and all that. So they looked all over the tumor. They cut the tumor. They ultimately called it malignant. So the point is that you have to work very closely with the pathologist for this and then use multiparametric imaging. So this is how the algorithms will look like. Basically, they're not colored in the paper, but initially I colored them so it's easier for you. But generally, first you want to remove these tumor-like lesions. And you know what they are: ganglion, vascular malformation, lipoma, I mean, any other unencapsulated fatty globules, fat necrosis, they are tumor-like lesions. So these should be taken out first. After that, you look at whether it's hyperintense, markedly hyperintense, predominantly hypointense, or intermediate signal. So 3 on T2, 1 on T1, right? That's what helps you. Whether you're looking at fat or hemorrhage, or you're looking at very bright, very dark, or intermediate signal on T2. So that's going to help you. Do they have calcification? Do they have specific location, hand or foot or intra-articular? So based on that, these algorithms are built out. In fact, we got a little bit of help there's a paper out from Ames from India where they have some algorithms like this. So ours are a little different, but they had some good algorithms in a review article. Okay, so based on calcifying tumors, so we have a calcifying tumor here, and these are calcifications. So malignant tumors can have calcifications, and benign ones can have calcification. Then you look for other features. So here you have calcification. It's near the joint. It's got some hemorrhage also in there. It's very heterogeneous on ultrasound. So the other thing we did was we included all modalities in this system, and they've characteristic features as you saw in the tables. So very heterogeneous, large, a little bit of edema around it is usually a bad sign. Small amount of peritumoral edema. If you have large amount of edema, that's usually benign. But a small amount is usually bad. So here you can see some edema, heterogeneous, very large tumor. So this should be a synovial sarcoma. It's near the joint. It's a heterogeneous lesion. It's very dark on ADC, which synovial sarcomas are. And this you can see there's some cystic changes also, which they can show. Here there is some tumor thrombus also in the popliteal vein. And here you can see this finally came out to be synovial sarcoma. But if you were to put in ST-RADS, it will be 5. If you were to put in soft tissue RAS, it will be 5. So that's what this is. Here's a companion case, 52-year-old. She came with left upper chest wall swelling for 1 year and it's steadily increasing in size. It's painless. So it's asymptomatic, but an increasing size mass. So that's the mass, looks heterogeneous, cystic. This is the mass, what it looks like. It's got some calcification here. And again, maybe some hemorrhage. So these are the cystic areas in the mass in the chest wall. So in this system, we don't have visceral tumors, but we do have tumors which are in the chest wall, pelvic wall, or abdominal wall. So we didn't use the visceral tumors because they can be gynecologic type leiomyosarcomas and all that. So we didn't include those. So liposarcoma in the retroperitoneum. So here you have cystic area. So this was another synovial sarcoma, again 5. So this is how algorithms look like. So we start with hyperintense on T1, which can help you if it suppresses a fatty lesion, if it doesn't suppress hemorrhagic lesion. And then we put categories in there. So like you saw in the ST-RADS paper, similarly in soft tissue RADS, you have these tumors which are in 2. So green is usually benign, blue ones, you got to do something about it. So here's atypical lipomatous tumor again. So that'll be 4. Elastofibroma will be 2 in the gluteal area. They happen in the chest wall, but can happen here also in the ischiofemoral space. Here's a simple lipoma. That should be 2. There's an ossifying lipoma. You have ossification here and just fat. That's 2. If you're worried, you can call it 3. These are usually 2. And then predominantly dark on T2. So here you have fibroma, calcifying aponeurotic fibroma. These are classic locations and appearances versus fibromatosis, TSGCT, desmoid. Now you're getting into 3s and 4s versus malignancies. So these go into 4 and 5. So intermediate grade and then malignancies. So here's a fibroma of the tendon sheath. And then very bright on T2, you have benign lesions like hemangioma, lymphangioma, etc. Then you get into the benign, probably benign myxomas, etc. Or these solitary fibrous tumor, and then these bad ones. So these are just a guide to you. But again, you're going to use that 5 or 6 scale, easy to use. You can go back to the chart if you wanted to look for which lesions lie where. So here you have a cystic lesion there. This is pre, that's post, and it does not enhance. It just becomes bright on pre. So always do a pre-contrast before post and also subtraction. So we again have that incomplete imaging or complete imaging in that as soft tissue at 0. So in this case, if I just showed you this, you'll say enhancing tumor. It's actually not enhancing. This is adventitial bursitis. It just gets bright on the pre-contrast. So you got to do pre in MSK whenever you do post. Unlike neuro, sometimes you skip the pre ones. So here's a typical muscle mass, very bright myxoma. Here's very bright mass, but enhancing. This was a myxoid liposarcoma. And there's another very bright mass, but has a little bit of fat in there. So a little bit of fat in soft tissue tumor is not a good thing, except for hemangioma. So this is a myxoid liposarcoma again. And then here is again very bright mass, but heterogeneous. Looks like a Baker's cyst. In fact, it's enhancing. So this was a synovial sarcoma in the joint. And then you have this heterogeneous mix of fibrosarcomas can be very bright. Again, myxoid component. This patient had left thigh mass, noticed 1.5 years ago, now about twice as large, so fast growing, very bright, very enhancing, and also bright on ADC, which myxoid tumors can do. And you can see an ultrasound looks ugly. So is it a myxoma or a sarcoma? It's not in the muscle. So it should be a sarcoma. So these are myxoid chondrosarcoma. So this is a misnomer chondrosarcoma. These are basically soft tissue sarcomas. Okay. And then you have predominantly intermediate signal, which could be a lymphoma, or you could have these other sarcomas, especially leiomyosarcomas and Ewing sarcomas, extraskeletal. They can give you heterogeneous intermediate signal. So this was high-grade pleomorphic sarcoma. which had these gray signals. So when we describe gray or white, you're looking at the in-phase image of the T2 Dixon, or you're looking at the T2 image if you're doing that without fat suppression. With fat suppression, everything gets bright. So this was a leiomyosarcoma. You can see very dark on ADC, perfusing a lot. This is after chemotherapy. It looks similar, but actually it's very bright on ADC now, so with some residual areas. And then they took it out and it came back in a month. What happened? Actually, they developed hematoma, which is similar, but it's darker on ADC and bright, sorry, darker on diffusion and bright on ADC. It's opposite of what you saw in the initial case. This was just a hematoma. You can see here peripheral enhancement. PET also was negative. We aspirated that. And then rhabdomyosarcoma, muscle-like, so they are grayish. So this was a recent case. And then hand and foot tumors have their own differentials, benign and then the bad ones. So based on that, they have RAD system. So all of that will be in the paper once it comes out. So here you have a ganglion, very classic, no enhancement right here. This was a Cowden's disease, which have big phallus, big head, etc. And they have colonic polyposis and can get hemangiomas. So here's a hemangioma in the foot. They had another hemangioma here in the area where I showed you the chondrosarcoma near the piriformis muscle. So these are all hemangiomas in that patient. This is Mefuchi. They can have multiple hemangiomas everywhere. So here is the hand of that patient. Another hemangioma near the tendon. But in general, call any solid enhancing lesion you see as indeterminate unless you have diffusion or other means to differentiate and use the scoring. At that time, you got to be thinking of any of these, give contrast, do diffusion biopsy or X-ray, and put that in the score somewhere. So this is a small enhancing lesion in the median nerve, and this was a synovial sarcoma. So I've seen a few of these now, 4 or 5 millimeter small size synovial sarcomas. So be very careful. This one is nodular fasciitis. You can see high on ADC. So that'll be your nodular fasciitis should be 2 or 3, whatever you want to call it benign. And then intra-articular tumors are usually benign. So you have tenosynovial giant cell tumor is 3, focal or diffuse. The synovial hemangioma, chondromatosis, ganglions, and then you can have a rare synovial sarcoma. I've seen 2 or 3 in my life. They're very rare. Mostly they are benign lesions in the joint. And then lipoma arborescens, chondroid lipoma, etc. So here you have a ganglion coming out the subscap bursa, benign. And here you have this thick synovium going along the ligamentum mucosum and also in the back. So this is tenosynovial giant cell tumor. Here you have a ganglion going along the nerve into the tibial nerve. So there's an intraneural ganglion. They usually have this garland appearance. So those of you who are coming for the IRI meeting, I'll show you some MRN signs, how to diagnose certain things. So this garland appearance, when you see it going this way or that way, these are usually intraneural ganglions. And then we have these bad ones, those with septations or those with a mass. So this is 4 ALT and 5 is a mass. That's myxofibrous sarcoma with the solid enhancement. So in our validation testing, again, we found similar results. Our ICC was 0.79, a little bit higher than point, I don't remember, 7.3 or 7.4 you saw in the previous system. And these are all experts right now from different institutions. So Mark Murphy is in there. Anybody you can think of in tumors are in there. And the overall accuracy was 82% with mean true. So category 6, we did it separately because this is post-tumor response. So the true positive rate compared to the reference standard was very high, 97%. So overall accuracy for qualitative diagnosis, when I asked them, what is it, synovial sarcoma or what, they were at 63%, which is expected. And area under the curve. And we had some readers who are very adept with diffusion, like Shivani, etc. They're in Hopkins, so I taught her. So they were at very high accuracy. That's why you see 63%. But if I give to a general public, it'll drop back to again between 50 and 60. So area under the curve for 10 readers was 0.83 to 0.99. And average year confidence was also higher. So similar to what we saw in our study here, it was 4.35 versus 4.1. We saw 4.4 versus 4.1, very similar. So these are the ROC curves. So I think this will be a good system, and you still have STRAD. That's a good system which is out there. So this is the conclusion. Ultimately, what you want to do is consistent communication between the teams, appropriate management, timely management, and finally collect some data for long term. So we can do some data-informed approaches to sarcoma care and help the society. So this was a team effort. You can see all of these people are in there in that system. So Julie is a pathologist, Edwin is a Boston oncologist, Carol Morris is in what's that place? Sloan Kettering. She's a surgeon there. Ian is our methodologist. And we have all these people from different places. You have heard these names. So Gambiz is from UCLA, Berang is from MD Anderson. Jonathan Samet was my fellow, he's in Northwestern now. And then Mark Murphy, Jim Wu from Brigham, now he's in MGH. And then these are our people. So Ty was my fellow, he's the vice chair now in Miami. And then Angela, he's a student. Flavio, Gitanjali is in UMS. Hilary is from Mayo Clinic. Shivani from Hopkins. Majid from UW. So you have all these people working on this. You'll have a good product coming out. Okay, so that's all I have, and we can do some questions. I think there's something in the chat.